So thank you all for uh, visiting or attending my presentation. Thank the organizers for inviting me. Thank you for the kind introduction that spares time for me. Yeah, so the story today is synthetic human relaxant 2 for heart failure with preserved ejection fraction. I'm the CEO of Relaxera. Of course, this is my conflict of interest for you to know. So let's talk about the rationale first. You might know 50% and rising of patients with chronic heart failure have heart failure with preserved ejection fraction. So we are talking almost 4 million in the EU, almost 3 million in the US, and rising. Alone all the patients in Central and Southeast Asia who are prone on the rise. That's the very same in all developed countries. And you should know that HFpEF prognosis is really comparable to that of heart failure. The patients Professor Schuler was talking about. In general, it's about 50% of patients dying within 5 years. So that's a grim mortality. It's deadlier than most of cancers nowadays. But in sharp contrast to heart failure with reduced ejection fraction, for HFpEF, there is no mortality-lowering pharmacological treatment as of today. Lately, there has been some good news. For instance, phase 3 trials in HFpEF using SGLT2 inhibitors, so empagliflozin, dapagliflozin, and of very late at the ESC in London last week, a phase 3 trial with finerenone, a mineralocorticoid receptor antagonist, had at least shown that they could lower hospitalization for heart failure, but still there was no sign of reduced mortality. So this is really an unmet medical need. And this is relaxin. It belongs to the insulin superfamily. So the structure very much resembles that of insulin. It was discovered more than 100 years ago as a pregnancy hormone. So in general, in rodents, it serves to facilitate birth. In humans, it's a little bit different. The major importance is in the first trimester. It is the master regulator of circulatory adaptation of the mother, and it serves to induce immunotolerance between fetus and mother, and it serves the implantation of the fetus. In humans, we have 3 relaxin isoforms. So when I say relaxin, I usually mean relaxin 2. It's not clear still if relaxin 1 is even expressed as a protein. And relaxin 3 is a neuropeptide. There is a cognate receptor for relaxin 2. That's the relaxin family peptide receptor 1, a G protein coupled receptor. And this is also a bit of a personal history of mine. So I can really say our group back at Charity Hospital 20 years ago brought it into cardiovascular medicine. So we were the first to describe endogenous relaxin is a player in human heart failure, very much resembling the natriuretic peptides, so with a compensatory mitigating role. We elucidated some of the key mechanisms of relaxin. Very interesting, we came up with the story that it is a real agonist at the glucocorticoid receptor without the notoriously known side effects. And we were the first to administer a relaxin therapy to stable HFrEF patients in a phase 1b trial 20 years ago. In addition, we did a lot of work on relaxin pharmacology. And this is why we think HFpEF is a job description for our peptide. That's the quite known and famous scheme of HFpEF pathophysiology by Paulus and Schöpe of 2013. I still like that very much. Bottom line is HFpEF is a whole body inflammation that is driven by obesity, overweight, smoking, hypertension, diabetes, and some other comorbidities. And this whole body metabolic inflammation leads to a whole body endothelial dysfunction. It leads to fibrosis. It leads to stiffening of the heart and the vessels. And in the myocardium, it leads to myocardial dysfunction, better known in the clinical situation as diastolic dysfunction. And as you can see here, Relaxin 2 is addressing almost all steps of this scheme. It has vasodilatory actions. It acts against endothelin 1, which is a major driver here. It improves insulin sensitivity. It has anti-inflammatory effects, in part dependent of the glucocorticoid receptor. It's a very strong antioxidant, for instance, targeting the nerve transcription factor. It inhibits vascular inflammation. It's, I guess, among the 2 or 3 strongest antifibrotic we know. I will come to arrhythmia effects later on. It's antihypertrophic, and it reverses the titin hypophosphorylation that is in large parts responsible for diastolic dysfunction. So if you ask me to cut it short, I would come up with that equation. So regarding signaling of relaxin, so it's anti-endothelin 1. It's an upregulator and protector of the nitric oxide cGMP axis, an agonist at GR. And the signaling also involves angiotensin 2 receptors, angiotensin type 2 receptors, and the Wnt signaling. So what is angiotensin type 2 receptors and Wnt signaling about, and what is behind this quite striking pleiotropy? Here we go. First, you should know this is the relaxin receptor, RXFP1. It's a G protein coupled receptor of its own class, very unique in its action because it requires a very intricate multi-step procedure to activate. This might be the reason why there is until now no one single non-peptidergic small compound that displays really full spectrum relaxin effects at this receptor. There's some biased agonists which are under development, but none of these agonists have the full spectrum signaling of the peptide. You can see here, so transmembrane loops, that's the so-called linker region, that's a leucine repeat-rich domain, and that's the so-called LDLA module. And relaxin needs to bind to the linker, to the LRR region, to a certain loop of the domain here. And this induces conformational changes, which allows the LDL module to switch on the signaling. So very, very multi-step and intricate. Then there is no such thing like canonical signaling for relaxin. It's really cell type dependent. We get to realize more and more that there is huge differences between overexpressing systems, so receptor overexpressing systems, and real cells. So, but the major signaling pathways are CAMP, protein kinase E, the nitric oxide axis, then a multi-tier inhibition of endothelin 1, both at the expression level and at the clearance level. It upregulates endothelin type B receptors. I mentioned this agonism at the GR. We have patented it recently. It's real binding there. You can prove it by MRI. And then this angiotensin type 2 receptor, it's a receptor that is only expressed in diseased tissue or inflamed tissue. And RXFP1 and this receptor get at least in close proximity, and there is a huge crosstalk. So this crosstalk is, for instance, responsible for relaxin's antifibrotic action. And finally, there is this Wnt1 beta-catenin-mediated myocardial rejuvenation. I will show you in a minute. So this is some data or some visualization of the GR thing. This is HeLa cells, and those cells were stimulated with either fluorescence labeled or native relaxin and insulin as a control for 1 hour. And you see there is a nuclear staining here with DAPI. There is GR antibodies later after fixation of the cells. And there is either relaxin or insulin. And compared to control, non-stimulated cells, you can see relaxin induces nuclear translocation of the GR, and it travels into the nucleus, as can be seen with both approaches here. But there is no such thing if you use the very related hormone insulin. And the role of that, for instance, is organ protection. So this is taken from a very nice paper showing relaxin effects in a model of mice liver transplantation. And this is cell culture, and you expose those cells to heavy oxidative stress, and up goes the transaminases, and down they go with relaxin in the presence of scrambled inhibitory RNA. But if you really specifically knock down the GR by that RNA here, the protection for relaxin is gone. And that's another example. That's from the paper where we described the GR interaction first. That's human macrophages stimulated by endotoxin. They secrete huge amounts of TNF-alpha and other pro-inflammatory cytokines. And you can see over different periods of time, there is a dose-dependent decrease of those secretions, and which is completely dependent of the glucocorticoid receptor. I was mentioning the role of Wnt in relaxin-related myocardial rejuvenation. So this Wnt1 beta-catenin pathway is completely responsible for the electrical remodeling we see under relaxin. I show you data in a minute. It is in part responsible for relaxin's antifibrotic and anti-inflammatory effects. So at the right side here, you can see normal Wnt signaling. It is a composite receptor here, and this receptor inhibits the inhibition of GSK3 beta towards beta-catenin, which is a very potent transcription factor, and regulates a multitude of genes. And relaxin ignites or stimulates the system via several ways. In some cells, it just upregulates Wnt1. We are about to elucidate that. It's not totally unraveled. In some systems, it just inhibits the inhibitor of the system, DKK1. And another fact is that there is a site feed-in here from the relaxin receptor via GI proteins and the PI3 kinase and the AKT kinase, which also inhibits this central switch here, GSK3 beta. So a very important pathway, especially in the myocardium. This is to show you this what I call rejuvenation. This is aged rats. So Fisher 344 rats, male versus female rats here, a 9-month versus 20-month age. So this is really old rats. And what you can see here, that aging per se means inflammation, fibrosis, and oxidative stress. So NF-kappa B, for instance, toll-like receptor 4, interferon gamma, cytokines, and TGF-beta fibrosis pathway. This aging was especially pronounced here in the females, but nevertheless, irrespective of sex, it is inhibited by relaxin. And that is why we call it a rejuvenation. Now, I like this review on animal models of HFpEF. And bottom line is clinically, there is different HFpEF phenotypes. And this is mimicked by different model phenotypes. And overlapping phenotypes are related to first aging, for instance, these aged rats. Then by hypertension, there are different models, for instance, angiotensin II infusion, and then the different cardiometabolic rodent models. And we can say we have found pronounced relaxin effects in all of these phenogroups. And I like to give you a very short summary on this. This is data by collaborators or friends of ours. So the group by around Sasser et al., and they infused into rats angiotensin over 3 weeks, and at day 8 of that period, relaxin started, here given as a continuous sub-Q infusion by mini pumps. And this is controlled. This is the increase in blood pressure by angiotensin, and this is the decrease with relaxin. And hypertensive organ damage is, of course, induced by angiotensin. This is albuminuria. This is a fibrosis index of the kidney, and both is almost totally reverted after 2 weeks of relaxin. This is, again, the aged rat, and this is about arrhythmia. Clinically, arrhythmia is the most important single cause of death in phase 3 HFpEF trials. So that is really, really relevant. And we all know as clinicians that AFib heralds usually a worse prognosis of HFpEF patients. So, and in this aged rat, after having received relaxin for 2 weeks, there is little inducibility of atrial fibrillations. So that means upon sacrifice, the hearts are taken out in a Langendorf chamber and then are stimulated. And you try to induce atrial fibrillation by different protocols, be it premature beats or be it burst pacing. And rat is vehicle-treated animals. You see, they mostly respond with sustained atrial fibrillation to those protocols. In contrast, the green ones are the relaxin-treated hearts, mostly no AF, and if it is inducible, then it's just a transient atrial fibrillation. So why is that? One pillar of that is antifibrosis here. So collagen goes down, which is especially pronounced in aged rats. But the other one is really electrical re-remodeling. Those rats have a slow, not slow, but little and depressed expression of the fast sodium channel, NaV1.5. And its expression goes up under relaxin, vehicle relaxin, also functionally, because this is a patch clamp experiment in a human iPS cell differentiated into a ventricular cardiomyocyte, and you see in rat that huge increase of sodium current. And together with an increased expression of connexin 4, a gap junction protein, it just expedites conduction velocity, which is, in our view, key to all these beneficial changes. And that's a different model. That's of the cardiometabolic phenotype. That's the ZSF obese rat. It's a rat with 2 different leptin receptor mutations. And those rats usually arrive at week 8 to 10 of age and are then fed a high-fat diet. And if you are lucky, as we were here, at week 18 to 20, they develop HFpEF. In some cases, because the model is variable, you have to wait until week 25 or so. But nevertheless, they develop HFpEF. And then, okay, we are taking echocardiograms just to follow up and, of course, to follow up the treatment. Then there is again this, what we call optical mapping. You harvest the hearts after sacrifice and put them in a Langendorf chamber. And then there are lots of immunofluorescence, ELISAs, and so on. And this shows you here that the model really develops HFpEF. So that's young, that is F rats. And you can see first, the ejection fraction here is preserved, first requirement. Then you see this clear decrease of myocardial relaxation velocity, the very same parameters as we used them in clinical echocardiography. Again, the key parameter in humans to define HFpEF, to define diastolic dysfunction, is E to E prime, and this goes up dramatically. And global longitudinal strain is diminished as well. So it really fulfills all the criteria of even human echocardiography for HFpEF. And last but not least, left atrium plays a major role in HFpEF, and there is enlargement as well, so by 50%. And we started with continuous sub-Q treatment by Alcid manipums for 2 weeks. And you can see here, that's a male group, the male cohort. You can see diastolic dysfunction by relaxin is reversed almost to week 10 levels. And the left atrial enlargement is again reversed to week 10 levels. So within 2 weeks. And of course, there is some increase in biomarkers. This is anti-pro-ANP, so an atrial natriuretic peptide. That's the levels in control rats. It increases 5-fold in the natural cause of disease and is decreased markedly by relaxin therapy. And here I'm coming back to antifibrosis and electrical remodeling in that model. You can see it's always vehicle versus relaxin. You can see there is an increase in Wnt beta-catenin signaling in the left ventricle myocardium. And we know from different studies that this is totally responsible for the increases in the fast sodium current and the connexin 43 expression. That's the gap junction protein. That's the fast sodium channel. So both responsible for increased conduction velocity. And in part, this plays also a role for antifibrosis. And you can see here the collagen 1 staining vehicle versus relaxin after 2 weeks. The question, of course, then arose how to administer a peptide for chronic clinical trials. And I think we've come up with a very good solution. Look, this image here, this is relaxin antibody staining of a left ventricular myocardium. The myocardium is taken 24 hours after the last bolus of relaxin of a 2-week therapy with daily shots of non-retarded full-length relaxin 2. And you can see 24 hours after the last shot, there is clear staining of the LV myocardium. This is probed with exogenous relaxin just to prove the specificity of the signal. So why is that? Because you should know we did, of course, pharmacokinetics. The plasma levels peak at 60 to 90 minutes, and the circulating relaxin is gone after 8, at maximum 10 hours. The point is, again, this very special receptor, which is neither internalized nor desensitized, in striking contrast to many GPCRs. It shows a very, very slow off rate. That means even in cell culture, even under washing buffer conditions, the effect lingers on. So that's the key to this phenomenon. So a lasting stimulation despite a short plasma half-life. And of course, I mentioned that there are many genomic effects which just need to be reignited from time to time. That means, obviously, it's good enough to push the swing at just the right time. That's our slogan for this, pushing the swing at just the right time. And from now on, this is all the what we call bolus therapies, so daily injections of 100 microgram per kilogram non-retarded synthetic human relaxin 2 for 2 weeks. This is diastolic dysfunction in the ZSF model again. This is now grouped according to sex. This is the females here. You see diminished relaxation velocity, which improves to pre-illness levels. One can say same thing with this parameter for diastolic dysfunction. Up it goes under relaxin. That's the natural cause of disease. And that's the left atrial enlargement, HFpEF, 2 weeks under relaxin, 2 weeks under vehicle, which tends to increase LA. Of course, variations here are higher. That's much of a methodological artifact here or problem. And the very same holds good of the males, except maybe for the fact that left atrial enlargement is even higher for the males in the natural course of disease. So, and here I'm coming back again to the electrical remodeling, both at atrial and ventricular level, and showing you the data with a bolus therapy. These traces here are atrial traces. So you have voltage sensitive dyes and pulsium sensitive dyes. You can really online monitor voltage and pulsium changes in the heart. And to the left here, this is vehicle treated animals or the hearts of those animals. And a typical example here, a premature pulse induces sustained atrial fibrillation. And a typical example for a relaxin-treated animal, the premature pulse is no longer captured, the heart is totally refractory, and there is no atrial fibrillation whatsoever. And as statistics here, you can say regarding sustained atrial fibrillation, it cannot be induced in relaxin-treated animals. Usually, the untreated animals have a chance of 60%. We have extended these investigations to the aged rats. I showed you pictures before. There it is even more pronounced because the electrical remodeling in those aged rats is even more pronounced, and the fibrosis is higher than in the ZSF model. So there is an 80% chance of inducing AFib in vehicle-treated animals. It's nil with relaxin, and it's very comparable to incessant ventricular tachycardia, so not inducible under relaxin, be it the ZSF1 male or the aged rat. And the odds are much higher for the vehicle-treated animals. So, and on the basis of all of this, and this is a huge leap now, of course, we are in the very process of preparing a phase 2 program for HFpEF. In fact, we are preparing a European seamless trial design, dose finding 2A, 2B study, 300 to 350 patients. Synthetic human relaxin 2 will be administered over 6 months via daily sub-Q injections using pre-filled single-use syringes, so like an insulin shot or a heparin shot. And we will include usual patients for HFpEF trials, so both HFpEF and HFmREF patients, that means LVEF will be higher than 40%. And we would like to do a certain risk enrichment here. We would like to include patients with high fibrosis risk, so they should at least have 2 out of those 4 risk factors. And the risk factors are paroxysmal AFib, or a moderately reduced eGFR, or manifest type 2 diabetes, or high sensitive CRP above 2 as a measure of metabolic inflammation. And that will be the usual endpoints for a phase 2 in HFpEF, of course, with P adjustment here. So NT-proBNP as the most established biomarker, 6-minute walk test, quality of life, the Kansas cardiomyopathy questionnaire. Then there will be secondary parameters, of course, including echo, AFib burden, and different biomarkers. And of course, safety parameters like eGFR slope, and then the harder endpoints, hospitalization, mortality, although it is understood that in a phase 2, you can most likely, but we are open for better, you can most likely only observe trends for that. So, and yeah, we are just collecting, so to say, interested clinical study sites. So if there should be any interest from any of you, you are very welcome. And that leads me to my summary, part 1. So in our view, HFpEF is still the biggest unanswered question in contemporary cardiology. Relaxin's unique receptor and signaling characteristics render it an exceptionally strong drug candidate. We think a multifaceted syndrome like HFpEF needs a pleiotropic approach, and that's the difference to the HFrEF approaches. And at preclinical level, the relaxin-2 concept is effective in all 3 phenogroups of HFpEF models. The peptide delivery reverses diastolic dysfunction, arrhythmia susceptibility, inflammation, and excess fibrosis. The atrial and ventricular antiarrhythmic properties of relaxin are clinically important. In clinical trials, AFib heralds worsening of HFpEF, and sudden cardiac death, which is usually tantamount to ventricular tachycardia or ventricular fibrillation, poses the most frequent cause of cardiovascular death in phase 3 trials in HFpEF. And second, with bolus therapy, signaling can be achieved with periodic pulses of the peptide, irrespective of its short half-life in circulation. And that's something I would like to emphasize. This in turn enables excellent therapy control and compliance in highly susceptible patients. HFpEF patients are especially prone to blood pressure changes, for instance, after increasing the diuretics dose or so. And it's just good if you can just skip or halve a daily dose. And then I hope I was able to show you that the entire signaling portfolio of the native peptide, especially the Wnt pathway and the GR-mediated anti-inflammation, which is free of the steroid adverse effects, is of the essence. And this pleiotropic signaling is most likely trimmed down by different relaxin modifying approaches. So we are preparing a phase 2 AB clinical trial in HFpEF. And having said this, I would like to express my thankfulness towards our partners. It's the University of Pittsburgh, Professor Guy Salama, where most of the animal experiments are done. It's the Florey Institute in Melbourne, which is our partner more for the basic science, for the receptor science. It's Immundiagnostik in Germany, who are helping out with ELISAs. The GR project is done in Melbourne at Willy's lab. And then we have a couple of esteemed colleagues in Amsterdam, in Bochum, in Paris, at the University of Porto. And I would also like to thank our different consultants here. I very much thank you for your attention, and I'm happy to take your questions.